Hello, and thanks for tuning in to the Society for Maternal-Fetal Medicine's webinar, Myth-Busting COVID Vaccines in Pregnancy. I'm Dr. Jackie Parkham, and I'm one of today's moderators. We've asked several maternal-fetal medicine specialists to provide answers and evidence to refute some of the most common misconceptions about COVID vaccination during pregnancy, and we've been hearing from our patients. You'll see their responses in the video that we're about to show. This webinar is being recorded and will be available on demand from the SMFM education site. We will also provide a PowerPoint presentation that summarizes the answers and provides references. Following the video, there will be a Q&A segment. You can enter your questions in the chat box to the right or submit questions anonymously using the Q&A feature at the bottom of your screen. We will try our best to answer all questions during the time allotted. And now let's watch the video.
Ragsdale, the Director of Fetal Intervention at University Hospitals Cleveland Medical Center in maternal-fetal medicine. The statement that the vaccines were developed very quickly is a true statement. The fact that they are unsafe because they're developed too quickly is the part that is a myth. Lots of pre-pandemic research went into creating this vaccine. There were federal pandemic task force that discussed how to create a vaccine in the case of a pandemic like the COVID vaccine pandemic. A lot of this came from HIV vaccine data and came from the Ebola virus and things like that. We also had a lot of things going for us. We had tremendous global collaboration from some of the smartest scientists and researchers and physicians in the world. There was early sequence of the full genetic code for the COVID-19 virus and widespread dissemination of that information. We had high infectivity rates and lots of volunteer participation. Typically when randomized controlled trials are done for vaccinations or for drugs, it takes weeks and months and years to enroll enough people to get adequate data to be able to determine if a vaccine or a medication is safe. And that wasn't an issue for the COVID-19 vaccination because people saw the tremendous devastation that this virus was causing worldwide. Over hundreds of thousands of people registered for the vaccine trials within the first week of them opening. Additionally, the part that was cut short was not the solid research and the safety data. It was all the red tape, all the bureaucracy, all of the paperwork that has to be done, and all of the roadblocks that we have in creating new medications. All of those things were put by the wayside in order to get this vaccine out and administered and in people's arms quickly and safely. We were able to fast track FDA approval. Typically, once data goes to the FDA for review, it takes somewhere between 10 and 16 months for that data to be reviewed and assessed. It has nothing to do with the safety of the data. It's just that's the backlog for the FDA to review data. And the COVID-19 data went to the top of the line and was reviewed immediately. So from the time the data was received by the FDA to the time that we got emergency use authorization was less than a month. And that's just unheard of in medicine for it to be reviewed that quickly. Additionally, I think we can't underestimate how much money was put into creating these vaccinations. The creation of a new drug or a new vaccine is a multi-billion-dollar endeavor. And that is something that globally tons of money was put into creating these vaccinations quickly and safely for us to get them in people's arms and try to turn the corner for this pandemic.
Hi, thanks for including me in this myth-busting COVID-19 webinar about vaccines and pregnancy. I'm Dr. Roxana Irani, and I'm with the University of California in San Francisco, and I'm a maternal-fetal medicine specialist. So in this segment, we're going to talk about, do vaccines change your DNA? And the short answer is no. How do we know that, though? Well, before we get into those details, we should probably talk about the different kinds of vaccines and how they work. So there's two main types of vaccines against COVID-19 available in the US. There's the mRNA type and the viral vector type. The mRNA types are the two-shot vaccines, the Pfizer and the Moderna, and the viral vector is the single-shot Johnson & Johnson. Both of those types of vaccines are injected into your arm muscle. And both have both inactive and active ingredients. And for the active, I included all of those big science words so that you know that they are very specific to a part of the COVID virus called the spike protein. And so that spike protein is what your immune response really reads when you get an infection with COVID-19. And there are inactive parts in both of those kinds of virus types, or vaccine types rather, stabilizing salts and sugars that are found in many common foods. For example, sodium chloride, which is just a table salt, and sucrose, which is just a simple sugar. And I should note that DNA is stored inside of the nucleus of your cells. So a very small part of your cells in your body. And the mRNA and spike proteins actually work outside of the nucleus. So the vaccines and the DNA, or the part that's inside of the nucleus of your cells, they never come into contact. I should also say that there are no microchips, tracking devices, or magnets found in any of these types of vaccines. And if you do have some common allergies, just know that there's no dairy, milk, egg, or meat derivatives found in these vaccines either. Specifically, there's no pork or gelatin, and there's no mercury found in any of these kind of vaccines. How do these vaccines work, and how do we know that they don't interact with our DNA? COVID-19 vaccines help protect our body by developing immunity, or the immune cells called antibodies, to the virus that causes COVID-19 without getting the actual illness. The vaccines do not work by giving you COVID. The antibodies are good protective immune cells that fight a COVID infection. So when you get common mild vaccine side effects after your first or second dose, that's your immune system working, not COVID-19. So the vaccines give you that small mRNA code, and your body turns that into a protein, which is a message that your body reads. And then your body can create those antibodies and give you protection. So the mRNAs do just that. Those mRNA vaccines have that short code, turns it into a protein, and then you develop an immune response. There's no interaction with your DNA at all. And the vaccine doesn't have a whole working virus for your body to fight. So there's no way that you actually get the COVID illness. The vector vaccines work in kind of the same way. If you think of the viral vector like a car, and the short COVID vaccine or the COVID-19 code is the passenger in the car, that's how that code is brought into the body. The protein is then made, and your antibodies are made after that. And again, there's no whole viruses transported into the body, just the code to help make the immune cells. But then how long do the vaccines stay in the body, and can that change your DNA? Well, your muscle cells, where it's injected, they break down the mRNA code soon after your body is finished using those instructions to make the spike protein, the message that your body needs to read. The mRNA lasts for a really short amount of time, just a few days, and we know that it doesn't travel very far. The muscle cells break down that mRNA into small, harmless pieces, which can't ever be read again. And there's many, many studies showing that those mRNA pieces stay close to where it was injected in your arm and into the lymph nodes around it. The lymph nodes are the part of the body that cleans the blood. So if you plan on getting routine mammogram after getting a COVID vaccine, you should check with your doctor because your lymph nodes might be a little overactive. We know that DNA and the vaccine never come into the contact with each other. So your DNA is not changed. And we also know that mRNA is really fragile and it breaks down super easy. And that's one of the reasons why these mRNA vaccines have to be stored in special freezers and at very low temperatures. And then what about those spike proteins? After the code is turned into the message, we also know that that message only lasts for a short amount of time. We think it lasts for about 2 weeks. And so that's why you're not fully vaccinated until about 2 weeks after the vaccine. And again, since it's not a full virus and all the proteins that the virus needs, it's only one small part of the virus, the message breaks down completely after that and doesn't give you COVID. So to answer the question, do vaccines change your DNA? The answer is no. Thanks very much.
Hi, my name is Dr. Mariam Nekvi, and I'm an assistant professor in maternal-fetal medicine at Cedars-Sinai Medical Center. Many women are concerned about the impact of the COVID vaccine on future fertility. Understandably, this is really scary for women. Many are wondering, okay, What if I get the vaccine today and then 5 years down the line, I have trouble getting pregnant? How can we be so sure that this vaccine won't make me sterile? What I hope to do here in the next few minutes is to dispel this myth that the COVID vaccine causes sterility. And so to start, we have to ask ourselves, where did this idea come from? Unfortunately, this connection between vaccines and infertility isn't new to COVID. In fact, the same was said about the HPV vaccine and several other vaccines that preceded it. The myth surrounding the COVID vaccine and infertility actually arose from a blog post, which has since been taken down, suggesting that there are striking similarities between the spike protein and a protein called syncytin-1. Syncytin-1 is involved in pregnancy implantation. And so the bloggers thought, will this vaccine then attack this protein and interfere with pregnancy development? The answer is no. And let's go over why. To date, there is no scientific evidence demonstrating a link between the COVID vaccine and infertility. Firstly, these two proteins actually have very little in common. Secondly, if this were true, we should also be seeing an increase in sterility from COVID itself, but we haven't. A study that was published in Fertility and Sterility found no differences in implantation or pregnancy rates between women who got the vaccine and women who didn't. Another study out of Yale looked at cross-reactivity of the COVID antibody to 3,000 proteins. They found no cross-reactivity with syncytin-1. Though it is true that fertility wasn't a pre-specified outcome in the initial trials, hundreds of thousands of reproductively aged women have now received the vaccine, and we simply have not found this association to be true. Lastly, menstrual cycles. Particularly on social media, there are concerns that the vaccine can impact your period. The reality is, we don't know if this is true. Menstruation is complex and affected by many factors. Initial reports, however, tell us that if periods do change, it is likely a transient effect. Coming back to pregnancy planning, what we do know is that the current body of evidence has not found any link between the vaccine and infertility. Our professional societies, including the Society of Maternal-Fetal Medicine, the American College of OBGYN, and the American Society for Reproductive Medicine agree that women who are planning a pregnancy in the future can safely be vaccinated.
Dr. Adi Hirschberg, and I'm from the Hospital of the University of Pennsylvania. Yes, it's true that you can get some natural immunity from having COVID-19. After getting the virus, most people will have detectable antibodies, but reinfection can occur. Reinfection means that a person who was sick or infected with COVID-19 once and then recovered can still become infected again. We know that with vaccines, everyone gets the same dose, and studies have shown 95% protection from getting sick after vaccination. When you have a natural infection, however, the level of protection likely varies depending on disease severity, meaning it is likely that an asymptomatic infection has different level of protection from someone with mild illness, who may have different level of protection from someone who had a severe illness. People who have more mild infection may have lower levels of antibodies than someone who is sicker. So what does this mean? If you take 100 people who have previously had COVID-19, 15 to 20 could get reinfected based on a predicted 80% protection for natural immunity. However, only 5 out of every 100 people who get an mRNA vaccine might get infected given 95% protection. In fact, a recent small study showed that unvaccinated, previously infected people were more than twice as likely to be reinfected compared to vaccinated, previously infected people. Other reasons to get vaccinated after infection is that we don't know how long immunity lasts after natural infection. And just like level of protection may be different based on severity of illness, length of immunity likely also varies, ranging from 90 days to 10 months and possibly longer. However, duration is more consistent from the standard dose vaccine. Early evidence also suggests that vaccination after infection stimulates an even stronger antibody response than either recovery or vaccination alone, and better immunity to new variants such as Delta, providing even more reason to get vaccinated even if you had a COVID-19 infection before.
Veronica Maria Pimentel. I'm a maternal-fetal medicine specialist at Trinity Health of New England in Hartford, Connecticut. I'm also an assistant professor of OBGYN at Quinnipiac University and University of Connecticut, and I'm the director of research for the OBGYN residency at St. Francis Hospital and Medical Center in Hartford, Connecticut. Young people do need the vaccine against COVID. Even though young people are not likely to get very sick, they actually can get infected with the virus, and they can subsequently transmit the virus to those who are at higher risk of severe disease. In fact, some young people actually do experience severe illness from COVID-19, And those who don't become very sick, those who are asymptomatic or with mild cases, they can actually have serious sequelae such as myocardial inflammation. The demographic of COVID-19 in the US is actually changing. And by that, I mean that the median age of confirmed cases in the US is becoming younger, and more young people are getting infected with the virus. There's also racial and ethnic disparities that exist in the infection rates, with young Black and Latinx people being at higher risk of getting COVID virus than their white counterparts. And this inequality exists because of healthcare inequalities and social determinants of health, such as access to transportation, quality and safe housing, as well as access to healthcare. The bottom line is that even if a young person doesn't get sick from the virus, the person can still transmit it to others and unknowingly get others very sick. And it is important for young people to do their part to help end the pandemic. The best way is to protect themselves by getting vaccinated. And by doing so, they're also protecting their family and their community. Like everyone else, they should also adhere to COVID-19 precautions, which include wearing a mask, practicing social distancing, good hand hygiene, and they should self-monitor for symptoms. If they have symptoms, they should seek care. And if they are diagnosed with an infection, they should quarantine themselves.
I'm Tori Metz, and I'm calling in from the University of Utah. I want to talk to you about how to address patient concerns about miscarriage and stillbirth with the vaccination. I think up front, it's really important just to very definitively tell them that there are not data that suggests that that occurs. There are very good animal data from Pfizer, Moderna, and J&J demonstrating that there's no increased risk with pregnancy. There are also human data, and I think that that's what patients always want to hear about as well. I typically talk to them about the CDC data, and those data come from the vSafe application that patients can download on their smartphone when they get the COVID vaccine. And so patients are asked to just go ahead and sign up for this. And from that, it says, were you pregnant at the time of vaccination? And that has allowed the CDC to collect data on a lot of women who received the vaccination during pregnancy. And their first report of that data came out actually in the New England Journal of Medicine, addressing this exact question. At that time, they had about 35,000 women who had received the vaccination in pregnancy. And of those, about 4,000 had signed up for the vSafe pregnancy registry where they could track pregnancy outcomes. And about 827 of them had completed their pregnancies. And at that time, the risk of miscarriage among the patients who'd been vaccinated was 12.6% for under 20 weeks. And that's very consistent with the population norms. And so those population-based norms are somewhere around 10 to 14%. And so right in the middle of that population, what would we expect at the population level? So I think we can really tell patients that we're not seeing any increase above baseline risk for miscarriage. Same thing with stillbirth. Out of those 800 pregnancies that they followed, there's only one that had a stillbirth, which is 0.1%. So again, nothing concerning compared to what we would see at the population level. So I think that the other piece of this is, people have worries about the placenta and how that might affect things, might affect stillbirth rates, miscarriage rates. And what's been seen by researchers is that there's no difference in how the placentas look among patients who've been vaccinated. So they really aren't seeing any differences in placental histology that would suggest that there's any adverse effects on the placenta. Of course, there are with COVID itself, but not with the vaccination. And so really that's what has made us all feel comfortable saying that people can get the vaccine anytime in pregnancy. They don't have to wait until they're outside of the first trimester. They can just get it as soon as they can, and that it is safe in a trimester of pregnancy.
My name is Adi Hirschberg, and I'm from the Hospital of the University of Pennsylvania. Most people in early pregnancy who take medications are worried about the chances of miscarriage or birth defects. This is why many people are hesitant to get a COVID vaccine, especially before 20 weeks. While pregnant individuals were not included in clinical trials, some people found out they were pregnant after receiving a vaccine, and fortunately, more than 5,000 pregnant individuals have been followed in the CDC vSafe registry to look at some of early pregnancy concerns, such as miscarriage, stillbirth, and birth defects. While miscarriage is the most commonly reported adverse vaccine-related outcome, miscarriage and other adverse outcomes from the vSafe pregnancy registry are similar to the published incidences in pregnant populations before the COVID-19 pandemic. Similar to historical data, most miscarriages occur prior to 13 weeks, and of note, those pregnancies that were complicated by congenital anomalies were exposed to COVID-19 vaccination in the third trimester, long after organs develop. Understanding that no pregnant persons who were vaccinated early in pregnancy had live births to collect data based on the initial results, more recently, first trimester and preconception vaccination were looked at in more detail. In a study of more than 2,500 pregnant persons who received at least one dose of an mRNA vaccine for COVID-19 preconception or before 20 weeks gestation, risk of miscarriage from 6 to 20 weeks was the same as the general population at about 11 to 16%, with most miscarriages happening early in pregnancy as expected and reported in non-vaccinated historical pregnant populations. Therefore, there is no reason to believe that vaccination before 20 weeks is unsafe based on either miscarriage or birth defect risk. Given the risk of COVID-19 in pregnancy, vaccination at any point is recommended.
My name is Dr. Omar Young, and I'm an associate professor of maternal-fetal medicine at the University of North Carolina at Chapel Hill. Some people have been asking, is the COVID vaccine a government experimentation? But I think it's important that we take into context why this is a propagated myth regarding the COVID vaccine. It's important to recognize that there is a cruel history of experimentation in American medicine. The history of gynecology in the United States stems from experimentation on enslaved African American women. And this is how we got knowledge about how to repair fistulas, parturition, and other aspects of labor and delivery management. In the more recent past, the Tuskegee experiment has been one of the paramount symbols of the cruelty of American medicine and experimentation. African American men were subjected to being withheld treatment for syphilis in order for the government to understand exactly what the natural life cycle of syphilis was. Unbeknownst to these folks, they were the source of experimentation. Therefore, it is not hard to understand why people, particularly African Americans, may be loathed or scared to have the administration of the COVID vaccine. However, we got to take into context exactly what is COVID-19. COVID-19 is an extremely serious disease that not only impacts the respiratory system, but can have an impact on the neurologic system, the renal system, and others, with many people having long-standing issues that have yet to be unearthed. What is the COVID-19 vaccine exactly? The COVID-19 vaccine is an mRNA vaccine that basically allows your body to make antibodies or proteins against certain genetic information on the virus itself. Many people say, well, why was this vaccine put into place in the first place? It was rushed. In fact, mRNA vaccine technology has been under development since the early 1990s. And it has been as such in order to assist with making better vaccines and increasing the production of vaccines so that they can be widely distributed. How mRNA vaccines work is that administration of the vaccine allows for the mRNA to enter cells and for the cells to work their machinery to make the specific proteins or antibodies that go on to target the virus. The mRNA that is contained in the vaccine is degraded by normal cellular functions, and this mRNA does not integrate into DNA. Many people have said, well, or you may have heard that COVID-19 vaccines allow for tracking of individuals. There is no such information for tracking within the mRNA that allows for the creation of the COVID-19 antibodies. A lot of people also are loath to take a vaccine because of the aforementioned history of American medicine. Importantly, African Americans have been involved in the creation of the COVID-19 vaccine. Specifically, Dr. Kizzmekia Corbett, an epidemiologist and immunologist, was integral in the development of the Moderna COVID-19 vaccine. When I'm talking to patients about whether or not to have the vaccine administered, I always want them to understand that having COVID-19 is much worse than actually having the transient side effects of the vaccine. So just to explain, what happens when you have the COVID-19 vaccine administered? You may have a sore arm for a couple of days. You may have some body aches. You may even have a fever. Those are signs that your immune system is working. Those are signs that your body is using that mRNA in the vaccine to make those antibodies, such that if you are exposed to COVID-19 and to contract it, you can easily fight off that infection. We know that the COVID-19 vaccines decrease the chances of you being hospitalized and or dying from a COVID-19 infection. So the government is not experimenting on you. The government is not tracking you. What the government is doing in this case is trying to save lives. I, as an African-American physician, totally recognize exactly what has happened in American medicine and how I and patients that look like me have been impacted by the biases that have pervaded American medicine. But I am supremely confident in the technology of the COVID-19 vaccinations. I myself am fully vaccinated, and I encourage all of my patients every day to become vaccinated. It is the only way that we're going to solve this pandemic, and it's the only way that we're going to return to some semblance of normal.
Hi, my name is Dr. Jackie Parkham, and I'm an MFM at McGovern Medical School at the University of Texas Health Science Center in Houston. This topic's really near and dear to my heart because I got vaccinated when I was pregnant earlier this year. So let's break down this myth into two parts. I'm going to show some of the key data to dispel this myth that vaccine effectiveness has not been studied in people who are pregnant or lactating. The first question is, will a person who's pregnant or lactating mount a strong immune response to the COVID vaccine? Several studies have addressed this question by looking at antibody levels after vaccination. Here I'm showing a graph from one of those studies. First, we can see that antibody levels for non-pregnant, pregnant, and lactating people increase significantly after vaccination. And importantly, antibody levels are similar between all of these groups, showing that pregnant or postpartum status does not weaken the immune response to vaccination. Second, you can see that the antibody levels are lower for both non-pregnant and pregnant people with previous COVID infection on the right compared to people who are vaccinated. So the takeaway here is that the vaccines induce a very strong immune response in people who are pregnant and lactating, similar to what we see for non-pregnant people. And a very important point that I always discuss with patients is that several of these studies have also shown that the antibodies produced after vaccination pass from parent to baby in utero and in breast milk, just like antibodies from the other vaccines we give during pregnancy, thus providing an important layer of protection for newborns. The second question is whether vaccination actually lowers the risk of infection and severe disease. Here we can learn from other countries with national healthcare systems that track vaccinations and hospitalizations from COVID. In this study from Israel of more than 7,500 vaccinated pregnant people, you can see that a week after the second dose of the Pfizer mRNA vaccine, the incidence of infections plateaus among people who are vaccinated, whereas infections continue to rise among the unvaccinated. In another recent study from the UK, researchers found that of more than 700 pregnant people admitted to the hospital with COVID-19 since the vaccines became available, 99.5% were unvaccinated. This study included the time period when Delta was the dominant variant. I find it helpful to use infographics like the one pictured here when counseling patients about risk. Together, these data show that people who are pregnant or lactating mount a strong immune response to the vaccines and that vaccination protects them from infection and severe disease.
I'm Andrea Edlow, and I'm a maternal-fetal medicine specialist at Massachusetts General Hospital in Boston, and I'm the chair of SMFM's Education Committee. While masks and social distancing represent important adjunct strategy, vaccination is far more effective at preventing severe disease, hospitalization, and death. Given the higher transmissibility of the Delta variant, which is 2 to 3 times as infectious as original strains of COVID, and viral loads can be 1,000-fold higher than the original strains of COVID, coupled with increased opening up of our society and lifting of restrictions, This makes it harder for entire households to effectively quarantine for a long period. So even if the pregnant individual thinks that that person is able to stay home, if anyone else living in the home is interacting with the outside world, this higher transmissibility and the increased opening up of society in general is going to make it difficult to effectively quarantine. So why not vaccinate and continue to use masks indoors for the highest level of protection for yourself and others? My name is Andrea Edlow, and I'm a maternal fetal medicine specialist at Massachusetts General Hospital in Boston. I'm also the chair of SMFM's Education Committee. Unfortunately, vaccine hesitancy, the arrival of new variants, and the delay in vaccine approval for children are making it increasingly unlikely that herd immunity of any type is achievable. Certainly, herd immunity without vaccines is unlikely to be achievable, given that symptomatic reinfection and even severe illness after natural infection have already been noted and are definitely possible. We know from direct comparisons that the vaccine offers better protection, at least as far as we can tell by much higher antibody levels compared to natural infection. And we know this for pregnant individuals as well as non-pregnant. In addition, many will die unnecessarily from COVID if we delay vaccination, hoping for an elusive goal of herd immunity from natural infection, which is highly unlikely to be achieved.
My name is Tori Metz, and I am at the University of Utah Health. I am calling in to talk with you about how to address patient concerns that perhaps COVID-19 isn't any worse than the flu. I think we all hear this from patients, and it's important to really be able to speak with them about the data we have available. And that data says very clearly that COVID-19 is worse than the flu. We have seen increased rates of hospitalization, increased risk of ICU admission, and increased rates of death compared to the flu. There is a really nicely done nationwide study out of France that demonstrates that among those who are hospitalized, the mortality rate with COVID-19 was much higher than in comparison to the flu, 17% in the COVID-19 group versus 6% in the flu group. So certainly much higher rates of mortality in the hospital setting. I think that the especially concerning thing is that most of these data came from a time before we were even seeing the Delta variant. And early data from the Delta variant suggests that it is much more virulent, that patients are getting sicker, they are requiring hospitalization, and they are requiring ICU care, and they are dying even more frequently than we were seeing with the other variants. And so I think that given that we already have data demonstrating how COVID-19 is worse than the flu, and now we have a variant that's even more severe, then I think this is something certainly we can address with data when we talk to patients. It's also important to consider when we're talking to patients the risks to the pregnancy themselves, because sometimes patients want to know what it means not just to them, and they're willing to accept the risks to themselves, but also to their pregnancy. And we have good data now demonstrating that compared to non-pregnant adults, pregnant patients have increased risks of needing ICU admission, mechanical ventilation, and of dying of COVID-19. We also know that pregnant patients are just at higher risk of pregnancy complications. We've seen increased risks of C-sections, preterm birth, and developing hypertension in pregnancy. So hypertensive disorders, preeclampsia, gestational hypertension, eclampsia. And so really speaking with patients both about the fact that we know that COVID-19 is much higher risk than the standard flu, and that it can also affect their pregnancy. I think those two pieces can really help when talking to patients about this misconception and really just encouraging them to get vaccinated to protect themselves and the baby.
Hi, my name is Heidi Leftwich, and I'm an assistant professor of maternal-fetal medicine at the University of Massachusetts. I wanted to first start to talk about what your patient might say to you as she's concerned about the COVID-19 vaccine. She might mention something like, why would you give me a vaccine that might cause a fever? Can the fever harm my baby? And so ultimately this myth comes down to a couple of parts. One is, does fever truly cause birth defects? When you do a quick Google search, it's interesting that the first few things that pop up are some of the older studies that are concerning for increased risk for open neural tube defects, congenital heart malformations, or clefts. And so ultimately, you start to think maybe there is some data to support that fever might suggest increased risk of birth defects. However, some of the later studies that look at confounding factors and have tried to tease out the actual risk of fever in pregnancy have suggested and proven that there's no increased risk for birth defects with maternal fever, even in the first trimester. I've listed some of the sources here, but ultimately, since 2017, there has been multiple publications to support that or refute that concern. And then ultimately, the second part of this is really the side effect profile. If you're looking at the safety and efficacy of a vaccine and you're worried about fever, ultimately you want to compare things like the vaccine to the actual disease. And so the vaccine has been shown to cause fever in about 3% after the first dose and about 14% of patients after the second dose. The highest rate of side effect profile would be pain at the injection site, which is 80%. I also talk to my patients that they might experience some muscle and joint pain, headaches, or fatigue. And ultimately, my pregnant ladies all laugh at me and say that they're pregnant and ultimately have fatigue all the time. But you do want to recommend and warn them against this side effect. Whereas the disease, you are much more likely to develop fever. Some studies actually support greater than 90 or 95% have fever. The fatigue, again, chills, sore throat, headache, loss of smell or taste, and muscle aches and pains. And then off to the side, the things that we've been looking at very intently, which don't have to do with fever, but are also concerning and need to be addressed with vaccine conversations, are the poor perinatal outcomes, the increased risk of hospitalization, invasive ventilation, and maternal death, as well as some emerging data with regard to intrauterine growth restriction, preterm birth, preeclampsia, and even stillbirth. So ultimately, the recommendations are to take acetaminophen with any sign of fever if you were part of the 3 or 14% to develop fever after your first or second vaccination, respectively. And then I would consider this myth busted in that the COVID-19 vaccine is recommended for pregnant women to prevent SARS-CoV-2 infection, which does cause severe symptoms and poor perinatal outcomes. We know now that fever is not proven to increase risk of birth defects. There are low rates of fever with the vaccine administration, and that acetaminophen can be used for any sign of fever. Thank you.
Veronica Maria Pimentel. I'm a maternal-fetal medicine specialist at Trinity Health of New England in Hartford, Connecticut. I'm also an assistant professor of OBGYN at Quinnipiac University and University of Connecticut, and I'm the director of research for the OBGYN residency at St. Francis Hospital and Medical Center in Hartford, Connecticut. Particles of the vaccine are not transmitted via breast milk. We have no reason to believe that the COVID-19 vaccines would pose a risk for breastfed infants or vaccinated mothers. The components of the vaccine are unlikely to make it to breast milk. Even if they were to go into the breast milk, they are likely to be quickly inactivated when the milk is digested, meaning when the baby drinks the milk, these particles would be inactivated because they will be digested by the baby. There are studies that are looking at mRNA COVID vaccines in breastfeeding women, and these studies have not found any serious adverse events in breastfed infants or of vaccinated mothers. Lactating mothers who are vaccinated actually, in fact, have been shown to pass protective antibodies to their babies via breast milk. Now, as we know, at this time, there is no vaccine for babies. It's up to us, it's up to the family, up to the community to protect babies from viruses. There are 2 ways that they can be protected. One is direct protection from the mom via a vaccination, where the mom can pass the antibodies to the baby, and any amount of protection will help. And it may help the baby from getting the virus, or at least may help the baby not get very sick. The second point is that when parents, family members, and community members get vaccinated, they are less likely to transmit the virus to others, including babies. I made the choice as a breastfeeding or lactating mother to get vaccinated. I was pregnant during the pandemic, delivered my baby shortly before the vaccines were available, and soon when they became available, I got vaccinated because I wanted to pass these antibodies to my baby to protect my baby, and I also wanted to protect myself and protect my patients. So I do recommend that pregnant women receive COVID-19 vaccines, and also I recommend that lactating women receive the vaccines as well.
Hello, I'm Dr. Heidi Leftwich. We're going to now open the floor to questions. Answering questions today are Dr. Andrea Edlow and Dr. Miriam Nakvi. You may enter your questions in the chat box to the right of your screen or submit questions anonymously using the Q&A button at the bottom of your screen.
I don't see any open questions yet.
Oh, there's someone that started.
Okay.
Do you want to discuss boosters? It's a loaded question. Would you like to discuss boosters?
Sure. Jackie or Miriam, do you guys want to tackle what you think about boosters?
Well, I think, we're chatting about this. Am I muted? Okay, no. We're chatting about this a little bit before this webinar, and, I think we're still awaiting, of course, like official rollout of these boosters to come out. I know, at least in California, a lot of the hospitals are sort of preparing for these things to kind of come out later in September. The recommendation that's going to be given for the general population, I think, is what we're going to be doing for our pregnant patients as well, right? So we're thinking that they're going to be recommending, there's been 8 month lag since that second boost to recommend a booster. There's no reason for us to think that that same recommendation is not going to be extended to our pregnant patients as we've been doing with the standard vaccine. And at least I know at our institution, that's what we're planning on recommending once these things become available. I don't know what you guys are doing at yours.
Yes, we're sort of universally applying the CDC's recommendations across the board, whether it's for pregnant patients or other non-pregnant individuals. And that also applies to vaccine mandates by employers and exemptions. We're not issuing any particular exemptions for pregnant or breastfeeding individuals or those planning a pregnancy, to your point about fertility and menstrual disturbances and things like that, which, you eloquently spoke on why those shouldn't be considerations that people are worried about.
Heidi, you're muted.
I think you're muted.
Sorry, I muted myself. In the Q&A, there's if majority of new infections are Delta and vaccine and booster don't prevent Delta, what's the point?
I think this is a common misconception. And it's sort of the idea of a breakthrough infection is sort of a misnomer. In general, all vaccines prevent disease, and we don't routinely go around the population testing individuals to see if they're carrying a virus or become mildly infected or asymptomatically infected with a virus after a vaccine. So I think the idea that vaccines don't prevent Delta is just not correct. They do prevent severe disease from Delta, and we've seen that time and time and time again, especially this summer as we have more unvaccinated pregnant individuals in the ICU on ventilators. And we've all seen these sort of quote unquote breakthrough infections of people who have a nasal swab or who have a mild illness and are tested for COVID because of our societal kind of testing tendencies and restrictions on where people can go if they have COVID symptoms. And we're finding a lot more mildly symptomatic or asymptomatic COVID infections, or I guess SARS-CoV-2 nasal carriage, essentially, without the syndrome of severe disease. So we know that the vaccines do work extremely well against Delta. They're 90% or more effective against hospitalization and severe disease. So I think, that's one important thing. And the same applies to boosters. And so I think to the extent that people's nasal carriage may be related to waning immunity, boosters in fact could make the vaccines even more effective to even testing positive for SARS-CoV-2. But the vaccines are working outstandingly well against Delta and all variants of concern right now.
Thank you both for your responses. I don't see any more questions yet. If we can put them either in the chat or the Q&A.
I'll just make a comment while we're waiting for some questions to come in. I think we can all identify the patients where talking about data and addressing myths doesn't actually work. Like they come in and they have maybe one or two things that they saw on social media or Facebook, and that's their reason. And us just coming at them with like, well, this study showed this and this study showed this, you can just tell, you can see them doing the internal eye roll, like they're not there for that information. And if you identify that kind of person, I try to sort of switch tactics to a personal appeal, or maybe I approach all patients this way, a more personal approach of, we're seeing a lot of patients in the hospital right now, and I know you're worried about hurting your baby. All moms are worried about their baby, but the best way to protect your baby is to protect yourself. And it's very heartbreaking. I saw a mom last week, an unvaccinated mom last week in the ICU, and it was extremely devastating for her family who were not vaccinated to see that, and for her and her baby to be at risk. And I don't want that to be you. And to just kind of make that more emotional appeal, I think sometimes people respond to that. And then the second thing is a lot of patients just haven't gotten vaccinated because of the barriers. So the logistical barriers, which we're thinking like, oh, it's so easy. Every drugstore has it available. But literally, if someone has a life, they're unemployed, they have children, they don't have childcare, they're trying to make their rent, it's not at the top of their list. So if you say from your clinic or the hospital triage, our clinic is open now, this is where it is, you can walk in and get it now. And I highly recommend it as your physician. We've seen a lot of people just take it up because we've taken that barrier away. So I think it's great to have all of these facts in our back pocket for people who want the information, but sometimes also just the like really clear, it's definitely recommended. I want you to get it. I care about your health and safety and your baby too, I think also helps.
Yeah, that's such a good point. Just kind of meeting people where they are and reading the room and understanding what types of information are going to be the most meaningful or persuasive to particular individuals is so important. And that's a big part of our role as physicians. It always has been. So, and the other thing I would say too is that I always try to remind myself, all the research has shown that there are not that many things that are effective to improving people's health as much as their own doctor taking the time to tell them something about their health that they're concerned about, even if it doesn't appear to make an impact in the moment. So I think, the more times that we can offer patients our advice and recommendation about this, even if it doesn't seem that it's getting through to them, probably the cumulatively this adds up and might diminish their resistance over time,
Agreed. And thank you, Jackie, for that. And then Omar actually also weighed in to agree with Jackie. I had a patient last week who stated she appreciated a non-biased, evidence-based approach that allowed her to reflect on how vaccination or lack thereof could have any impact on her and her fetus. Again, I think that we have this wonderful relationship with our patients. This trust has been created, and it is nice to be able to speak one-on-one with them and have such an emotional conversation. We do have another question. If a patient has had and recovered from COVID, does she need to be vaccinated? And I know this was kind of one of our topics in the actual PowerPoint, that maybe kind of speaking towards maybe the timing and some of that might be really helpful for this question.
Jackie, do you want to tackle that? Because you had some information in your question about natural infection versus vaccination.
Yeah, so people who've recovered from COVID are still eligible for vaccination, and it's recommended that they get vaccinated because, again, it's going to be essentially a booster, right? That first shot's going to boost your immunity against COVID, and so we should be encouraging all patients to get it. The timing, I feel like there was a time frame that the CDC recommended that we wait for that vaccination to happen. Do you guys remember the exact number
3
of days?
months.
From natural infection.
Yeah, it was 3 months.
I've definitely seen people do it in
Shorter.
the 2-month window. And especially now with Delta and the increased transmissibility and things. And it also, obviously, we know that the CDC probably has to make a blanket recommendation, but not all, SARS-CoV-2 infections are equal. And some people we know that some people who have an incredibly mild infection may end up having, like symptomatically may have lower titers than individuals who are severely ill. And so, I think to that extent, it may be a more individualized discussion with patients. But the study that you showed and other studies have shown that natural infection titers are down here and vaccine titers are way, way up here. And we don't know that titers, the only determinant of the fitness of immunity, and T cells also have a lot to do with it. But I think to the extent that titers can be a proxy for how good people's immunity are, there's no doubt that vaccine provides so much better antibody levels than natural infection. The last thing I was going to say, just if no other questions have come in, is to Jackie's point about meeting people where they are. I think a lot of the people who have a lot of vaccine hesitancy in pregnancy, I do think it comes from a place of not wanting to hurt their fetus. And so sometimes it can be effective to remind people of the data of that sort of secondary benefit of vaccination in pregnancy that we use all the time as a public health strategy, like with the pertussis vaccine. Or even the influenza vaccine, which is probably more similar to the COVID vaccine in that we give it first for the mom's health, but it also has the secondary benefit of crossing the placenta with the antibodies and giving antibody protection to the neonate who can't be vaccinated against these pathogens, at least until 6 months of age. So we can say, not only can you protect yourself, which protects your baby by ensuring you remain healthy, like you said, Jackie, but also your baby's going to get some antibodies from you and will have some amount of protection against COVID until the baby themselves is eligible to be vaccinated. And so that's also something that you can remind people of. It's not the main driver of why we want people to be vaccinated, but sometimes that can be compelling to people who want to do everything the best for their baby.
I think it actually is the main driver for our patients, right? I mean, all mothers know they're like thinking about kids first and their baby first. And so focusing on the baby as a message, I think works. One follow-up question I get from patients, or one comment is, or plan, is that they'll often say, well, I'll just wait till I'm postpartum because the baby's going to get breast milk antibodies. And I don't think we've done a good enough job of conveying to them the difference between vaccination during pregnancy and getting those antibodies that cross the placenta and stay in the circulation and are long lasting, versus the antibodies that are transferred through breast milk, which are like a surface coating of the respiratory and GI tract and aren't there for that long and depend on constant consumption of breast milk by the baby. And so I think that it's kind of a nuanced point, and people aren't, it's not that easy to convey the nuance sometimes, but just to say, you want both hits, like you want this layer of protection and this layer of protection if you can provide it, and also not waiting till like 2 days before you deliver because you're not going to get that benefit.
Right.
So those are some of the common things that I think we also can try to do to get them to get the vaccine during their pregnancy as a fetal or neonatal benefit.
Yeah, I get tons of questions about the durability of antibody protection from breastfeeding, and it's basically probably 1 day. Or if your baby is being, supplemented with formula, it's probably incredibly low amount of protection on those mucosal surfaces. It's certainly good. It's better than not having it. But the IgG that you get from the transplacental passage is much more durable and could last anywhere from 3 to 6 months, depending on if you were vaccinated at, in the second or early third trimester compared to, like you said, late third trimester. And we don't know enough about the maternal titers from first trimester vaccination, but because of how high they are, probably those titers will still be high at birth and will have transferred to the baby too. We're actually actively studying this now, but I think it's important to impart that idea to patients that if you really want your baby to have long lasting and durable immunity to the extent that the baby can have any immunity, it really comes from getting vaccinated in pregnancy. And being vaccinated while breastfeeding is good, but as the second you stop breastfeeding, all the protection is gone. And it's unlikely that it will confer protection to, your 2-year-old if you give them a breast milk smoothie. It's another question I get all the time. Like, can I give some of this to my 2-year-old to protect them It's like, not unless they aspirate it all over their nasal passages and drink 6 smoothies a day of your breast milk. But I think a lot of people have misconceptions about the protectiveness of just lactation alone.
Yeah, definitely.
We're getting close to the hour. I don't know if any other questions came in.
No other questions came in, so we have about 2 minutes, so we might just give everyone back and have the grace of 2 or 3 extra minutes in your day. So we'd like to thank everyone for attending the webinar today. Please look for the recording of the webinar and the PowerPoint presentation on education@smfm.org. Thank you again.
Thanks, everybody.
Thank you to all of our panelists.
Thanks so much.